Good morning and welcome to Psychiatry Grand Rounds. As a reminder, if you are a attending resident or medical student who would like to register for attendance or CME credit, you can call into the phone system. The number is posted in the lobby. The Grand Rounds Committee asks that you silence your cell phones and refrain from unnecessary use during the presentation. This morning I have the pleasure of introducing Dr. Emilie Cook. She is a fourth-year pathology resident at East Tennessee State University, and she completed her undergraduate studies at Tennessee Tech University, graduating with a Bachelor's of Science in Biology. She received her medical degree at DeBusk College of Osteopathic Medicine, and she is going to be doing a forensics fellowship at Wake Forest University. Please welcome Dr. Cook.
Can you hear me, I guess? Or can you not hear me? Maybe that's a better question. Okay. So today I'm going to be talking about fentanyl and analogs. It's like a big topic in forensics, and I'm sure with you guys too, the patient populations that you're seeing. I have nothing to disclose. So what I want to talk about today, try to get through, is just the basic pharmacology of fentanyl, the stats on the opioid epidemic in the national level, and then also in Tennessee and in our region, how we do postmortem testing on fentanyl and analogs, and then the dangers of the analogs as far as being exposed to patients, or in our case, at the morgue or on scenes with these analogs and fentanyl. So our first case, a 57-year-old male who was found down at home. And this was kind of the case that made fentanyl a little famous and was in the news. So this was in 2016, and this was Prince, who was found dead at home at the age of 57. His cause of death was fentanyl toxicity. And then a couple more recent stories that have been in the news. So a fentanyl overdose killed a 10-year-old boy. Seized fentanyl was enough to kill everyone in the city of Columbus. Fentanyl drives another record year of overdose deaths in Ohio. And then a little closer to home, for the first time, the TBI found fentanyl laced with cocaine in our state. And then also just a couple months ago, right before I did this presentation originally for pathology, there was a duo outside of Nashville that had been putting fentanyl in with heroin and meth and then selling it to all their customers. So what is fentanyl? It is a synthetic opioid agonist, and it's used for pain relief and analgesia. It was patented in 1960 from Janssen, and it's got a very rapid onset, so it's used for breakthrough pain and then anesthesia. Schedule 2, so it's got a really high risk of abuse, but can also serve legitimate purposes. It can be used in patches, lollipops, epidurals, IVIM, pretty much any way. And then how we kind of break it down in forensics, and what we're looking at is if it's going to be pharmaceutical or non-pharmaceutical. So if it's prescribed and made in a lab and regulated versus illicitly manufactured in a factory or someone's basement. And this is going to be coming from China, Mexico, and Europe. So here's just a visual aid showing our morphine is our baseline in this photo. Heroin is going to be 2 times as potent as morphine, and then our fentanyl is 100 times as potent. So how it works with our opioid receptors, we've got 3 classic receptors, mu, kappa, and delta. So fentanyl is primarily a mu receptor, and those are located in the brain, brainstem, peripheral sensory neurons, and then some in our GI tract. It can be further broken down to mu 1 and 2, and then those can all be classified as MOP or more, so either opiate peptide or opiate receptor. If you're doing reading, they can call it any of those interchangeably. So what about people that aren't taking opiates? How are the receptors being used? Normally, if you're not taking an opiate, then it's going to be stimulated by an endogenous peptide. So that would be an endorphin. So this is my daughter Elizabeth. So you can get endorphins by eating chocolate, or everybody talks about the runner's high. So exercise is also a good way for endorphins. So those can also attach to the opiate receptor. So here, just to show our mu1, so after we break down the mu, our mu1 is normally our happy things like analgesia. Mu2 is more of our bad side effects, so that's going to be vomiting, respiratory depression, urinary retention, and then the physical dependence. Our endogenous peptides, like the beta endorphin, is an agonist, and then our drugs that we're prescribing, like fentanyl, codeine, morphine, are also agonists. And then later in the talk, I'll just touch on naloxone, which is an antagonist. So just a little bit more about how they work. The drug or the endorphin is going to hook onto our opiate receptor, and that will inhibit the voltage-dependent calcium channels. So then that's going to decrease our CAMP, and then it blocks the release of the pain transmitters. So that kind of is how it leads to the euphoria in basic terms. Fentanyl is very lipophilic, so it can cross the blood-brain barrier rapidly. So it's fast in, fast out. You have a fast onset of the drug, and then it wears off a lot quicker than, say, morphine, who's not as lipid soluble. So it's going to take longer for your patient to feel morphine than fentanyl. And also morphine is going to stick around a little longer than fentanyl will. So our pure opiate agonists, like fentanyl or morphine, are going to stimulate our receptors, and theoretically how the pure ones work is that they're going to go in a log linear fashion. So your degree of analgesia is limited only by symptoms. So whether that be respiratory depression, or in most of the cases that I see, it would be death. But the patient can continue to take it, and they're never going to max out on side effects like how good they're feeling, or their high is never going to, I guess, level off. So in contrast to that, it's going to be our partial agonist like buprenorphine. So it's going to have a ceiling effect. So after they reach a certain amount of drug, they're going to level out, and that's as much as they can produce. So here's just a visual of that. So we have our full agonist, so it's obviously fully on the receptor, versus our partial, which is only partially doing it. So no matter how much you give, you're never going to get the full receptor covered. And then here's our antagonist, which is obviously going to reverse the receptor. So here's fentanyl. So this is how it keeps going. So the patient can continually take the drug, and they're going to keep having either the good effects or the bad effects until they stop taking it, they have respiratory depression, or they die. Versus buprenorphine, so after they get to a certain level, they're going to have that ceiling effect. And that's not to say that someone can't overdose from buprenorphine. They're just not going to have the same high effects that you'll get from fentanyl. And then down here is our naloxone. So obviously you get no opioid effects from that, and it's going to be blocking the receptor. So with our pharmacology from that, fentanyl's normally metabolized to the despropionyl fentanyl, which is also known as 4-ANPP, and then a few other metabolites that are in a lot smaller concentrations. So we don't really focus on those in our tox reports. The 4-ANPP is a well-known metabolite, so if we see that in a report, then we'll know that fentanyl was there. However, with all these new analogs, it's also been seen as a precursor to some of the analogs, which doesn't really make sense, but that's what the labs have been finding. So another thing about fentanyl is that it's metabolized by the CYP3A4 system. So if you have an inhibitor to the CYP3A4 on board, they can increase your fentanyl levels. So also, like, different people have different CYP3A4 inhibitors just in themselves. So your friend may have a different inhibitor than you would, which means that you would be able to metabolize it differently just based on your genetics. So what is the opioid epidemic? It's an explosion of opiate overdoses and deaths, and what Wikipedia says, which is what I normally go to first, is a rapid increase in the use of prescription and non-prescription opioid drugs in the United States. So in 2009, drug overdoses surpassed motor vehicle accidents and guns as the leading cause of accidental death in the United States, and it's continued to rise since then exponentially. One of the theories about how this has happened is that people were given all these prescription opiates and drugs, and then how that leads to heroin is kind of questionable. But they think, like, with everyone cracking down on the opiates, they're not able to get the drugs that they used to get. So then people were turning to the street to get drugs. However, that increased the price of the street drugs, and people were able to get heroin cheaper than they could get oxy on the street. So basically, it's just all about money and then people being desperate trying to get drugs. That's one theory. So this isn't a new thing. This is from before I was born in 1987. So it's been going on for a while. This was a talk. Dr. Furslew helped me go through some old stuff to find it. And then back in this article from '87, it says, clever clandestine chemists have been known to synthesize potent analogs of fentanyl as substitutes for heroin. So the analogs, like our carfentanil, have been around since even back in then, so 30 years. And just for some data, this is from the CDC. So here we can see the major climb since this is January 2015 to February of 2017. So our brown is our synthetic opiates, and we can just see the exponential climb that we have here in opiate deaths. We have an increase in our heroin and cocaine and our other opiates, but the fentanyl is the highest by far. And this is the same data. This is just doing number comparison. So the one that I've highlighted here is where fentanyl would be in the synthetic opiates. So in 2016, there was 10,000 deaths, and then in 2017, it hopped up to 21,000. Just in 1 year span, it pretty much doubled. So. And then a little closer, this is Knoxville. So this is going to be right down the road from us. In 2016, they had 62 drug overdose deaths that include fentanyl and analogs. So out of all the cases they signed out with drug overdoses, about a quarter of them had fentanyl and analogs involved. And I don't have all the data for 2017 yet. They haven't released it yet. But this was just for the first half of the year in 2017, and they had already surpassed the number for the entire year of 2016. So they already had 74 deaths from fentanyl and analogs. So another thing to notice here is that out of all those deaths, a lot of them are the analogs, not just straight fentanyl. So it's not what it was before. It's kind of evolving. And then some more data. This is also from Knoxville. So in these cases, the cause of death was not deemed to be drug-related. So it was an accident, like a car crash, a suicide, or a homicide. But these patients still had drugs on board. So in these cases, there were 117 that had some type of fentanyl or analog on board, even though it didn't contribute to their cause of death necessarily. And then just this is a entire statewide data for Tennessee and Virginia. So 2015, we had 169 deaths related to fentanyl. The next year, it hopped up to 294. And then in Virginia, 2015, 225. And then they just lost their mind. And in 2016, it went all the way to 622 deaths just by fentanyl. So see, that's a huge increase here. So the user demographics, like the people that we're going to end up seeing at forensics or just in general that you guys may see coming into the ER or however you'd be interacting with them, they are young white males. So about 80% are going to be Caucasian, a range from 25 to 45 years old, and then 2/3 of the patient population is male. So the route of injection, or excuse me, the route of administration predominantly is injection. One study showed about 80% was being injected. This from CDC shows that 45% have evidence of injection, so we can see obvious track marks on their arms, or we find a needle in their arm at the scene, I guess. And then 21% have evidence of snorting, ingestion, or smoking. And then something that really stuck out to me is that everybody always thinks about the fentanyl patches, but only 1% of these cases were found with patches or were even prescribed the patches. So it's very negligible what's actually being prescribed as patches that's being abused in these cases. So what we see at autopsy is pretty nonspecific. The patients will have pulmonary edema, some urinary retention, and then cerebral edema. So it's like a triad that you're always looking for, but it's not necessarily specific for these cases. So obviously if they have track marks, that helps. But so the fentanyl and heroin connection, the effects are going to be really indistinguishable from each other. If you just see someone, you wouldn't be able to tell if they were on fentanyl or heroin. The potency is obviously higher in fentanyl, but the duration of action is going to be a lot shorter. So the estimated fatal dose for fentanyl is 2 milligrams, and then if the patient is tolerant, it can be a lot more than that. So what is the heroin and how is all this coming into our country and what's happening? This is what would be basically being shipped into our country. So this is coming from Mexico and South America, and 90%. These are bricks of heroin, so they can be different colors, like this would be China white, and then this is the black tar. The East Coast is more known for the white, so anything in this area is going to be like the lighter colors or whiter tan of heroin. And then on the West Coast, it's the darker browns and black. It also can be marked with a logo, so like one person said it's kind of like Starbucks or Dunkin' Donuts, like if you want the scorpion or the stallion of heroin, I guess. So they take the pure heroin, pretty much like 90 to 100% pure heroin, and then it's going to be cut down with an adulterant. So what they're doing a lot of times is putting in diphenhydramine or something that's going to be causing drowsiness or I guess a euphoric type state in addition to the heroin. And they're also cutting it with sugars, baby formula, and even borax. So basically, like if you have a China white, it could be like 60% sugar instead of heroin. So what people are actually buying on the street, if they are buying heroin, is about 15% pure compared to what's coming in the country that's like 95% pure. And then it's going to be packaged in little bags, so this is what people would be actually purchasing. So we're living in a world where you just can't trust your drug dealer anymore. And the CDC data shows that almost 65% of fentanyl-related deaths also have heroin or cocaine along with it. So people could be thinking that they're buying heroin or cocaine, but actually their dealer or someone else has mixed in this fentanyl in with it. Whether they know it or not, it's happening a lot. So our second case, this was one from our forensic center right across the road. We had a 25-year-old male who lived with his grandmother. He was found unresponsive by his girlfriend laying on the bedroom floor. So drug paraphernalia was identified at the scene. There was a needle and syringe on his desk, and then a spoon with a dark discoloration in the bottom of the bowl next to that. So his blood drug screen was positive for opiates, UDS, fentanyl, meth, and opiates, and this was sent out for quantification. So his quants came back with carfentanil, cyclopropylfentanyl, 4-AMPP, morphine, meth, and basically nicotine, and then the naloxone was used in resuscitation attempts for him, so that's Narcan, so that's why that's there. All these the first three here are going to be analogs, so carfentanil and then cyclopropylfentanyl. So what is carfentanil, the elephant in the room? Carfentanil, for a visual aid again, this is morphine, and then our heroin 2 times, fentanyl 100 times. So carfentanil is 10,000 more times or more potent than morphine is. It is commercially used as a veterinary tranquilizer in elephants or bison or any large animals. We don't have current blood concentration ranges in humans because it was never meant for humans. It was meant for elephants. It was also manufactured by Janssen, the same one that made fentanyl, and that was back in 1974. And just as a side note, this was also possibly used as a weapon in Russia. There was a group of rebels that had taken hostage at a theater, and the Russians used fentanyl and carfentanil to basically get everyone in the building down. Unfortunately, 125 people died because they didn't have access to Narcan. So, and this is another one from Dr. Furslew from toxicology. So it says the fentanyl we never thought anyone would be stupid enough to traffic, and that's carfentanil. So here is our heroin. So this will be a lethal dose. This is fentanyl, and then this is carfentanil. So the amount that could actually kill you is tiny, like a grain of salt. So where's this stuff coming from? This is just a website I found when I Googled it, and there's probably like 50 or more from that. So this is a Pure Chemical store. Feel free to order it. Just a couple $100. It seems pretty legit. So people can just package this up from other countries and ship it over here. And if this one gets caught or this one gets, busted, there's going to be another one that pops up like the next day under another name, and it's going to be the same people. So this is one of the ways that this is getting into the country now. So after looking at that visual aid showing fentanyl, heroin, and carfentanil side by side, you could see that getting carfentanil into the country would be a lot easier because you're only going to need like a tiny bag of sand versus a brick of heroin. It's a lot less expensive to manufacture, and then if you're the dealer, your clients are going to be really happy unless they die and end up with a medical examiner. So it's going to be a really good high. So this is just from our forensic center. I went through all the toxicology data over the past year or so, and we've had all these analogs just in our region. So within the counties that the forensic center serves, we've had carfentanil, acetylfentanyl, acrofentanyl, cyclopropylfentanyl, furanylfentanyl, parafluorobutyl, tetrahydrofentanyl, furanylfentanyl, and then the precursor 4-AMPP. So I thought we lived in a nice little town, but I guess there's a lot more stuff out there than you can imagine. This is from TBI. This was where they found 10 kilos of fentanyl in Tennessee. This was tested to be carfentanil, so like a lot of different appearances. You can have the lighter color or the darker color. This was heroin found in Washington County that tested positive for fentanyl within it, mixed within it. And then this one is what a 30 milligram oxy tablet would look like. And then when TBI tested it, it was actually a tablet of fentanyl. So they're using pill presses and actually making fentanyl to look like other drugs now. And this was the same thing. This was in 2015. They had a big drug bust of what looked like 30 milligrams pills of oxy. And then when they tested it, it actually turned out to be fentanyl. So our third case, this is in Florida. On the side of I-4, a man and wife were found close to their vehicle on New Year's Eve. The police pull up to the scene. The car door was open and the vehicle is still running. There's 3 children in the back seat watching a video, and no drug paraphernalia was found on the scene, so not in the car, not with the people, nothing. So this is a dash cam. They were just sitting on the side of the road when the police officer pulled up. So their autopsies, there was no sign of trauma, foul play, nothing abnormal whatsoever. They were samples sent for toxicology. So what we normally take at autopsy is going to be blood, urine, and vitreous. Special circumstances, we may do something extra, but it's pretty much always those routinely. We do a screening test in our toxicology lab that's going to look at the change of absorbance. So different drugs are going to have different delta absorbance, so depending on that, it would come back as positive or negative. Our fentanyl antibody is showing up with the fentanyl analogs, because as I'll show you, they have pretty similar chemical structures. So we've been seeing quite a few of those pop positive just on the fentanyl screen. To confirm that it is fentanyl or an analog, it's sent out to an outside lab where they do mass spectrometry. So mass spec is a powerful tool. So basically, it's really complicated, but to get it's a mass to charge ratio, and every chemical has a different mass to charge ratio and a different spec. So the data that we get back is kind of like a fingerprint for that specific chemical. And there's going to be databases full of what every chemical or drug looks like. So basically, the peaks and ridges are unique to that drug. So like I was saying, they're very similar in formula here. So this is fentanyl, and then these are going to be all the analogs. So basically, they're just throwing on an extra ring or doing whatever they can to make it just slightly different so it won't come back as a drug that's already in the system. And this is just an example of the mass spec. So basically, for fentanyl, what you're doing is looking at your high peaks. So every drug's going to have different numbers of high peaks. So like this one is 245, and then for this one, the profile is 303, 304, and 187. So that's kind of like the fingerprint for that specific drug. The tox came back on that case. The wife's blood showed 23 nanograms of fentanyl plus an analog, and the husband showed 40 nanograms for fentanyl, and then a smaller of that same analog. So as far as the spec, the drugs that they're creating, we don't have data in the spec database to show us what it is. So when this gets sent out to NMS labs where they do the mass spec, it says that it cannot be confirmed by a library search. So they can let us know that it may be similar to fentanyl or a fentanyl analog, but they don't have any data currently that can tell us exactly what it is. So basically, you would need further investigation and testing to prove that it's something else, or you have to wait for them to find the analog and say that it's the same thing. So in the world of forensics, there's no money like a lot of other places probably, but if someone dies of cocaine and then a possible analog, is it worth spending the money to ID the analog? So it's really good for statistics and being able to look back, but I'm not sure if it's worth the money of somebody that already has a small budget to be able to go back and do that. So basically, if you have tox coming back negative and your patient is acting crazy and their UDS is normal or something, it could be an analog or something that's not getting picked up, because most urine drug strains won't pick these up at all, so it could be something. So our last case, where I just hit on safety and then I'll be done. A 22-year-old pharmacy student was found unresponsive while working at a compounding pharmacy. He was noted to be fine approximately 10 minutes prior to being found collapsed on the floor. So his toxicologic testing revealed a blood concentration of 0.21 nanograms milliliter of fentanyl, and then he eventually died within that week at the hospital. His cause of death was contributed to transdermal fentanyl exposure. So This is a really controversial case because they say, like, well, we don't know that he didn't just snort some fentanyl and no one was looking. So the big debate now is whether people are safe being around these analogs or not. So this is more for scene investigation or in forensics, but with, I guess you guys, it could be if you're exposed to someone coming into the ER or seeing a patient coming into the office, what they could have on them or have in their pockets, I guess. But the American College of Medical Toxicology says that the risk of clinically significant exposure is extremely low, and incidental dermal exposure or absorption is unlikely. So that's a good thing. And this is for scene investigation. So if they think that there is a fentanyl analog, for scene investigations now, we need to be wearing PPE, boot covers, cap, goggles, nitrile gloves, a mask. So it's pretty serious. So obviously, if you're around someone and they start acting confused with pinpoint pupils, then you're going to be concerned. So our reversal for this, if we're like out on a scene or exposed with a patient, is Narcan. So it can be intranasal, intramuscular, or intravenous. And then a Vizio. So this was interesting. When it first came out, it was $575 for the 2-pack, and now the list price is $4,500. So they're definitely capitalizing on the opioid epidemic, where our ambulances and forensic center are having to have Narcan on site with them. So the way that that works is just that it's going to knock the opiates free from the receptor. And basically, if the person fails to respond to an adequate dose of Narcan, you can exclude opioid toxicity. So what is an adequate dose for something that's 10,000 more times or more potent than morphine? That's another controversy that everyone's been looking into. So some cases in the ER, they're saying that they're having to give 8 or more doses of Narcan just to overcome the carfentanil or the analogs. However, the American College of Medical Toxicology says that despite anecdotal reports that higher than usual doses may be necessary, they don't believe that that's true. So they think that just normal amounts should be fine. So in conclusion, this epidemic does not appear to be slowing down or going away. If the urine drug screen doesn't match with a patient history or presentation, it could be an analog or some type of fentanyl that we're just not seeing or able to capture yet. So the users of these drugs may or may not have knowledge of what's in them. So just because someone's doing heroin, or even if they tell you they're doing heroin or cocaine, it could have this mixed in with it and they would have no idea. And their dealer may have no idea. And their mom definitely has no idea. So these drugs are powerful, can cause a swift overdose. So just don't be complacent and make sure to protect yourself if you're touching anything, especially on the patient or in their pockets or anywhere. Just be safe. So just want to thank the forensics team and Dr. Ferslew for sure about helping me with the toxicology. So if anyone has any questions.
I just had a quick question. You mentioned that they cut it with a lot of other things, active and inactive. You mentioned that sometimes they'll have stimulants in it, and sometimes Benadryl and those kinds of things. So what effect do you think they're trying to get? Because those are sort of two opposite ends of the spectrum. So is it they're using stimulants to maybe enhance the euphoria or to combat the drowsiness? And what do you...
I think for the Benadryl, it's just to kind of go with the euphoria, but I'm not really sure why they choose certain ones, except that it, in theory, is supposed to make it better. Or instead of having so much of the heroin this drug can have a similar effects and be a lot cheaper.
I want to thank you for this presentation, but also, do you know how much of this effort for the opioid at least was done to inform the public or social media? Do you have any idea how much they spend to inform the kids and the society that we have deal with this problem?
I don't know. I know that I've seen some things on the news about it, but I'm not sure. I highly doubt that a lot of the people, especially that we see at the forensic center, knew that there was fentanyl in what they were taking. So.
The benzodiazepines are also metabolized on CYP3A4 and variably competitively inhibit CYP3A4. So I'm wondering to what extent that's been studied in concomitant use of fentanyl and regarding ODs, the extent of impact, the overlap of the 2 and 3A4 activity.
I don't know, but that's interesting. I didn't know that. I'll have to look into it. Thank you, guys.